Okay, so we're going to go ahead and get started for this afternoon. Thank you for your patience as we worked out some technical pieces. As you are all aware, hopefully you're in the right symposium, we're going to be talking about family interventions with a sort of a CBT orientation. So I don't want to take up too much time with a general introduction to that. But I will go ahead and introduce Shirley Glynn from UCLA and from RAISE. I told you I was going to be very, very quick to get us started. So, Shirley.
Yes. Okay. All right. Okay. The good news about being in the basement is we know you had to look around to find us. So it's only the hale and the hearty who made it here. So thanks. Okay. I am, in some ways, I think our set of talks today is going to be kind of like a funnel. I sort of am the more generalist, and then we're going to go closer and closer to the real specifics of CBT for psychosis. And just to let you know, I'm with the RAISE project, RAISE-ETP. So that's the randomized trial, and I am Shirley, and I'm a clinical psychologist from UCLA. Okay, this is what I'm going to talk about. I'm going to offer a little rationale for why we involve families in first episode care, then a little bit of data on the role of families in recovery. I'll do an overview of RAISE Navigate very quickly, just so you know a little bit about it. And then I'm going to talk specifically about our family intervention in RAISE. All right. And this is a quote I really love. This is from Yeats, and it's John Kane uses it a lot, and we like it. It's how we think about working with first episode folks. Okay. So it will be obvious to some of you, probably many of you in this room, why you would even want to do work with relatives of people with serious psychiatric illness. But you'd be surprised at the number of clinics you go out to, and clinicians say, they're adults, why are you inviting your families? That's not our standard of care. That's not really what we do. So we always feel we're sort of, to some extent, trying to change the culture. But when you think about it, first of all, there's a literature on EE that suggests it may play a role in relapse and first episode psychosis. We know that consumers often live with families, and so there's this reverberating tension in the system about, either the person's having symptoms and the family's worried, or maybe the family is struggling and that's worrying the clients. People are often unfamiliar about how to access mental health care. One of the transitions, most kids, people between 20 and 25, 30, if they're not on birth control, they're not on regular medication, they may not be getting anything approaching regular mental health care. So they think of going to a mental health person like you do when you have a very serious illness to see the doctor. And then when you feel better, you don't come anymore. And helping families and the consumers understand that's different. People may be confused. Also, one of the hard things is we heard a lot today, and I want to be very respectful of it upstairs, about we should also be thinking about people who are over 40 who have a first episode. Totally agree. But most of the people we saw were in their early 20s, and of course their job is to separate from their families, but then they get some sort of thing that's making them more dependent on their families. And navigating that, both for the families and the consumers, can be really hard. And sometimes we get relatives who discourage participation in treatment. They get that medication, they look it up on the internet, they realize how bad the side effects are, and they're, you don't need that. So it's a problem. Okay, so let me tell you just a little bit about RAISE-ETP. Bob talked about it this morning, so I won't belabor the point, but I do want to say that it's team-based, shared decision-making, a real resiliency focus, which we'll talk about a little bit more. And we have 4 components, psychopharmacology, and then 3 psychosocial. IRT, which I'll talk about briefly, supported employment and education, which now I'm sort of primarily responsible for in our dissemination program, and family education. All right. And just to remind you all, this is a randomized control group. It was raised, developed to be used in regular mental health clinics in the US. And about a third of the people had Medicaid, a third had no insurance, and a third had private insurance. So it's sort of a broad range. Our goals were basically to help people get back to work and have a better quality of life, typical clinic staff, and we have data. Our primary data are from 2 years. These are the diagnoses we accepted. People couldn't have been on medication or have had treatment for more than 6 months, which was primarily medication. Okay, and this was a randomized trial. People could go into Navigate. That's the RAISE psychosocial stuff and medication we're talking about, or community care. This is our, I don't know if I can make this work. Okay, I'm going to make my one political joke as a US person right now. This is Hillary country. This is Hillary country. This is Donald Trump country. Okay, so those are our sites, and that's how that goes. Okay, but you can see we were spread all over. All right, and you may have seen our outcome paper. We got good results. Although, you know, there was definitely room for improvement. There was significant improvement on quality of life, work, and stuff like that, but room for improvement as well. This is the one kind of new finding that I have right now for you. We just started looking at the family data. This is family burden, and this is community care, and this is Navigate. Our Navigate clients overall were worse at baseline on pretty much all the measures. So as you see, their families were also more burdened. You see there's a little bit of an interaction here. And actually, there's a condition by time interaction. So basically, burden was dropping for both, but burden for family members dropped more in the comprehensive psychosocial treatment condition. Though, of course, we can't attribute that just to the family treatment they got, because the consumers they love were getting a bunch of things too. Okay, so now I'm going to talk a little bit about our family intervention. All right, first of all, I want to just, this is a figure that was in the outcome study, but just in case you didn't, we had something called the SURF, where you would ask clients monthly, what services are you getting in both conditions? So these are the people that got customary care. This is month. By month 3, what you see is these are folks who have just been come into a first episode of psychosis study. And what you see is by month 3, less than 10% of the families are involved in their care. And it just basically drops. That is, I think, US care, I would say. What you see is these are the Navigate people where we're really working hard to get them into care. And so for about 9 months, we're kind of close to 50%, and then it drops. Of course, we would have liked to be here, but we're there. Okay, all right. Let me just talk briefly about our intervention. Our intervention incorporated some CBT principles, but it's not as focused as some of the other talks you'll hear in the next few minutes. Basically, we use the kinds of things you get in most MFG programs: education, develop a collaboration, be flexible. I'm going to talk a little bit about IRT as well. The interesting thing we wanted to do is we wanted to mirror what family members were learning and doing in the treatment with what the consumers were doing. Now, the consumers may have been going to IRT alone. IRT is our individual treatment. But even if they were going to IRT alone, some came to family sessions, some didn't, that was okay. But we wanted the families to know what skills they were getting and to try to be able to support them. So this is a little bit about the consumer treatment. It's individual resiliency training. The big thing we were working on is trying to help people be more resilient, all right? So these are the principles of the individual training that then we were matching. And this is the schedule, and I'll show you data to indicate we basically carried the families. Pretty much if they came with us, they were getting about 12 sessions. So they were getting pretty much the first half of IRT. So just as in IRT, they were doing assessment and some goal setting, then education about psychosis, relapse prevention. We didn't do, obviously, processing the psychotic episode, but we then spent a lot of time talking with them about coping with stress and how the family members could develop their own resiliency. All right? These are additional IRT, more advanced topics. Most of the families had left by then, so we weren't trying to match this as much. All right, so again, these were the topics we covered. So, you know, it would be a session or two about psychosis, medication, coping with stress, developing resiliency, the things people need to know. Okay, this is how we organized it. People would come in for a couple, 2 or 3 sessions to get oriented, typically with their family member, with their ill relative at that point. They would, the family members would have an assessment. If the ill relative would come, we would include them as well, take care of our release of information. Families would then typically come for 8 to 10 sessions while the client was doing IRT, supported employment, getting psychopharmacology. At that point, after about 10 sessions, they'd be discharged to either monthly basically to monthly check-ins, and to coming back with problems when they had them. Okay. So, as I said, about 10 sessions, relatives, clients needed to consent, but, you know, about a third of the time they didn't come to the sessions, they just let their families come and be fixed, which was their idea. Fix them. Okay, so I want to present a little data to you, pretty much about uptake and then predictors of uptake. Because I think it's enlightening when we think about developing programs. About 30% of this national US sample, people didn't consent to their families being involved with us at all. And even for research interviews. So from the get-go, they were saying, I do not want my family involved. Needless to say, a lot of this was about estrangement. Although occasionally it was also people saying, I don't have any family. If people had families, they tended to be living with them. And we had very few people that were in conjugal relationships or had ever been. 2/3 of the sample, almost 2/3 of the sample, had relatives who had at least one face-to-face contact with the Navigate team. So at least once a Navigate person could sit down with them. And half of the relatives, what we were seeing before in that picture, had at least one educational session. And if they came, I'll show you in a moment, if they came to one, they usually came to 5 or 6. And not surprisingly, mothers were the primary relatives who came. This just is a little bit about people coming for sessions. So the average number of family sessions we had was 12.5. This is of the 144 who came at least, the relatives came at least once, okay? Again, about 2/3 of the time the client was present, about 1/3 of the time they chose not to come. And the big other thing to note here is that family education, people were getting about 6, almost 7 sessions of family education. And even though we were offering them monthly, but some people came with a long time, and then with monthly check-ins, again, we would have thought maybe this would be 5 or 6, but really most people didn't, they got the education, they felt good, they wanted us just when they needed a little extra help. But again, you see, some people just wanted to come for a long time. Okay, this is the distribution of services. So this is people who we never met versus everybody else. And what you see is what I'm saying all along, that roughly people were getting between 10 and 15 sessions or so, if the relatives came. Okay, 2 points I want to make. One, what were our baseline predictors of engagement? First of all, quality of life. You know, that basically, if people were getting along better with their family members on the quality of life, the first item on the quality of life scale, they were more likely to bring them into sessions. We were much better at engaging Caucasian folks than any other ethnic groups, people who were living together. And then this one was done by my statistician by mistake, but it turns out smokers. We were more, we had, so what is this? If they were using tobacco, they were more likely to come, which I think in our sample was probably a proxy for SES, actually, because I think in the US, basically it's lower SES people who smoke at this point. But surprisingly, drugs didn't make a difference. Which is what we were trying to find out. And so if you do a logistic regression, where we really, people who were younger, people who got along better with their families, people who were not Black, and people who were not using tobacco. That's really who we got. So if I were to do one take-home lesson for us, I think it's obviously the inverse. Those are the people we need to work on targeting. Different cultural groups, people where there's more struggle in the family, those kinds of things. People who are perhaps a little older. Okay, finally, I want to speak something about clinical challenges. I'm always amazed when I read these articles and they have, you know, we did this, we did that, it was great, everybody came and everything was wonderful. Okay, that isn't always my life. And what I would say is there are a lot of clinical challenges in doing this work, in part because many people have very significant life challenges before anyone in their family develops a psychosis. And for many of the families we work with, the fact that somebody developed a psychosis is not the worst thing that's happening in their lives. So the kinds of things, you know, we have our little handouts and we talk about education and what does the word schizophrenia mean to you and all that. But, I mean, the background is you've often got blended families where you had, typically it's a mother with a son and a father who's new to, stepfather who's new to the picture, who is very unhappy that this son is living with them and unhappy and not likely to be leaving anytime soon. Single parents often, mental illness with multiple family members. The poignancy of sitting with a 42-year-old woman who has fought schizophrenia for 25 years and now has been told her son has it. And her heartbreaking thought about what have I done to my son and is he going to have a life like mine? It's the kind of thing that you're doing your little, well, here's positive symptoms and that what, but you're managing this undertone, which is intense. Relatives who use alcohol and drugs with consumers, that was sort of a common thing with us. As I said, people who had trouble taking medication. Relatives whose own lives were hard, so it made their resources were limited in what they could give. And then cultural issues. I mean, we had a fair number of immigrant families, Filipino, Vietnamese, South America, Russian, and really trying to, and therapists who knew a little bit about it, but not a lot. It's hard to be a cultural expert if you only see one or two people like that in your lifetime. So they really had to get up to snuff quickly, as did we. The one good news about this, and I've done a lot of work in this area, I think it's really true that at least how it works in the US, I think, is the families who come to the US tend to want to be acculturated pretty quickly. They're the ones who came. So they were a little more willing to think about like Western ideas and such. Okay. Let me say one other thing. I have talked with you about the challenges and how I don't want to be naive about when I'm doing, people talk about family education like it's just so easy. You just go in there and you say a bunch of facts or whatever, and then people understand what they need to do and they go forward. I think it requires an incredible amount of clinical skill, because what I really think happens is people come in with their worldview, whatever it is, and you're trying to overlay a little bit, kind of the biopsychosocial model or whatever model you have, while you're promoting recovery, while they're terrified to the extent they're paying attention that a bomb has just gone off in their family. So I think it's a really complicated thing, and what I think is it requires a whole lot of skill on the clinician's part. But also, I guess the final thing I'd say is I've been struck by the strength and the generosity of a lot of the families we've seen who are really going the extra mile, you know, the 4th rehab for their kid, the 3rd time they're getting them out of jail, because they're really trying to make sense of a horrible thing that's happened. Okay, finally, so this is my summary. There's a strong rationale for involving families, we think. There are unique issues in family work, but they can be addressed. Data from RAISE and Advocate indicate we can involve families, but there's variability in uptake and we have work to be doing. And that here are the kinds of things that I myself want to pay more attention to in terms of ways we have to strengthen engagement, who I'm going to target down the road. Okay, I think that's it. Thank you. So I guess that's it.
Okay.
All right.
So thank you, Shirley. I'll take a couple of questions. And,
Luana.
you need to talk into this for some reason.
Hi, wonderful talk.
Thanks.
Wonderful talk, Shirley, and I think the work you guys are doing is amazing. I'm excited for you. I'm just curious about engagement because you know from my work that engagement with family or loved ones is one of the most key factors, I think, to get the actual client to stay in treatment. And I wondered what kind of things you guys did for engagement, and I'd be happy to talk with you later about ideas.
I mean, it's a great question. I mean, obviously, we engaged 2/3 of the people, so there's some people we didn't. We do think home visit, flexibility around home visits, we think that's important. We think the flexibility about saying the consumer could or could not be there, because some people didn't want them and some people did. And the flexibility about the length of the treatment. Basically, what I think is foot in the door. Don't ask them for a big thing. Say, meet with me once, and I'll be nice. Oh, and the final thing is use every clinical skill you have, because the only thing you have to offer them at that moment is it feels good to be in the room with you. You know, and then you sort of build on it. Okay.
Great, thank you. Thank you very much. Just for time's sake, thank you. Oh, I'll put this down. Okay, so we're going to the second one, which is me. So I'll introduce myself when we have some slides, perhaps. And while we're waiting for this to come up, Kate Hardy, I'm a clinical psychologist at Stanford University. Can you hear me okay? No, I say thank you for there we go. How's that? Any better? Fantastic. In my head, it always sounds very, very loud, but okay. So from Stanford University, I'm going to present and talk about a pilot study that we did, a workshop for family members supporting individuals with psychosis, trying to convey CBT skills to those families. And this was a dissertation project that my student, Liz Zagier, was working on. So she couldn't be here today, so I'm presenting on this. And I'm guessing I'm going forward. No. Do I control this? Do you control this? Who controls this? There we go. We've got it, the technology, excellent. So I'm going to do a little bit of background, like Shirley has already touched upon some of the aims of this study, our design, what we actually did in terms of the intervention, the results, the conclusions, and then future directions that we want to focus on. So some of the things that Shirley's already touched on is the importance of involving families in this type of work. And I think the fact that you're here now tells us that you're already supporting this, you're already behind this as a model, that if we're working with individuals with early psychosis, we should probably be involving the families as well. But for some reasons behind that, obviously we know the onset of psychosis occurs during a time when young people are typically still closely connected with the family. We know that caregivers can have positive outcomes on recovery. Some of the data has shown reduced hospitalization stays, reduced relapse. But we also know that the impact of psychosis and caregiving on a family member can be really huge for that family member. And it's been well documented in the Schizophrenia Commission report and by NAMI this year, the National Alliance of Mental Illness in the United States. We also know that pretty much across the board, caregivers aren't provided sufficient support, despite often being the first line of supporting a young person experiencing psychosis. And as such, they've really been termed the invisible healthcare system, that we very much rely upon family members to be there to support the young person or the person with psychosis when we can't be as professionals, and yet don't typically receive the support themselves that they may need. Obviously, family-focused interventions exist, but due to training, implementation, resources, funding, they can be very difficult for families to access. And so typically what families are receiving, accessing, if they're out there looking for support, might be community-based family support groups and psychoeducation that do a lot. They're a great place to start, but we would also be saying that perhaps there's more we can be offering too. It's been stated that family intervention should be a feature of early psychosis service provision and coordinated specialty care, as we've talked about with the RAISE project, but not always routinely available due to funding, resources, that kind of thing. And just moving on for a second to thinking about the individual therapies, we know that CBT, cognitive behavioral therapy, has been recommended as a primary individual treatment model for early psychosis, NICE being one of the places that's been recommended. And so what we did when we was developing this, and I'll talk a little bit about how we developed this out of a range of interventions that we'd been doing. We wanted to see if those skills that we know are helpful from CBT could be disseminated and trained to family members as a way of supporting their own mental health and supporting the mental health of their loved ones. So essentially our question was, can family members benefit from learning CBT skills to support their own mental health and their loved ones? In terms of what we did, developing and piloting the CBTP workshop-based intervention that was aimed at family members, and evaluating specific intervention outcomes, so perceived knowledge of CBT skills and the techniques, confidence in how to apply those skills and techniques, and then using measures, the experience of caregiving inventory, we looked at psychological distress, and also expressed emotion. So note there, because this was a pilot, we were only collecting data from the family members, not from the consumers. And then also we have qualitative feedback, so in the written form, on the workshop, on the elements that are involved. So we also aim to analyze that qualitative data to support future family interventions. So essentially we invited family members to participate in this workshop. Our eligibility criteria was caregivers of adults aged 18 to 28 years, so trying to get that early psychosis population, with an onset of psychosis in the last 10 years. That was possibly a little bit longer than I would have liked, but we were struggling with recruitment initially. And then we also set a standard or a limit of a minimum of 15 hours face-to-face contact per week. So we really wanted to capture individuals who were coordinating, integrating, interacting with their family members. We recruited through our own clinic, the Inspire Clinic at Stanford, local family support groups who really got behind this. Actually, that was a stage at which our recruitment blew up. Everything had been going very slowly until I started speaking to the support groups, and then I started getting requests from many, many miles away to come and do the workshops. And I was like, no, we need to do the first one and pilot it and get the data before I start signing up to anything else. But I think that really spoke to the need of what people wanted, just the hunger and the thirst out there for this. We had 46 participants enrolled in the study. The degree of attrition, 27 participants completed all 3 sessions and all measures, which included measures through to 1 month post-booster. In terms of who we served or who participated, our family members, we had 16 males, 30 females, ranging from 38 to 75, with a degree of diversity, 2 African American, 9 Asian, 3 Latino, and 32 white, which I would think probably reflects the makeup of that local area of Palo Alto. I don't have the data there, but we did have a mix from family members as parents, family members as siblings, as spouses, and also identified family members that wouldn't fall into any of those brackets. And like I say, we didn't collect data directly from the consumers, so this was reported by the family members, but predominantly the consumers had a diagnosis of schizophrenia. Because we struggled with recruitment initially, we changed the recruitment age from 18 to 28 and made it a little bit higher, but our mean overall was 25, so we're still in the early psychosis piece. And predominantly, they were living with the caregiver, so well above that 15 hours standard that we set. These are some of the measures that these are the measures that we administered. So at baseline, post-workshop, post-booster, and 1 month follow-up, we administered the knowledge and use of CBT skills scale that looked at what did people know about the CBT skills that we were training, and then how confident did they feel applying them? Because obviously there's a huge difference between knowing something and then putting it into practice. So it was somewhat of a proxy, stepping away. Obviously, this isn't a situation where we can necessarily go in and watch somebody using these skills and rate how faithful they are or how competent they are in these skills. This was a proxy for that. Then we administered a family questionnaire to look at expressed emotion, the experience of caregiving, inventory to look at appraisal of the impact of the loved one's mental health diagnosis, and the Kessler psychological distress scale, and they were at baseline in 1 month. 1 month follow-up, sorry. In terms of the intervention itself, this was a 2-day weekend workshop. I'm sure that many of you will be familiar that when we're working with families, we're typically also working outside of traditional hours. If we'd have run this workshop during the week, I think we'd have had a lot less uptake because obviously people typically are working. With a half-day booster session 2 weeks later. Now, there was a slight issue with this, and this was neither myself nor my student were culturally savvy enough to realize that we'd scheduled this over the Super Bowl weekend, which I think hit our attrition. So, slight problem. Because the Super Bowl happened to be in Palo Alto that year for the first time and that's American football for those of you who don't know. For the first time in 50 years, it was a big deal. So even if people weren't into the football, they actually didn't want to be on the roads because it was just absolutely jammed. So note to self for next time, figure out what sporting events are going on within a 10-mile radius and avoid it like the plague. And this workshop that we put together built upon previous half-day and one-day family workshops that I'd conducted. So back in 2014, I, along with Doug Turkington, Sarah Ty, and Deborah Lampshire, put together a one-day workshop in the UK that was very, very, very well received. And then last year I'd done a couple of half-day workshops for local groups. And it was through the interest, through the feedback from the families that we sort of developed this pilot. Incorporated CBT-informed components to educate family about CBT techniques to support their own mental well-being and the mental well-being of the loved one. Now, it's really important to note that in no way, and we certainly emphasize this in the workshop, were we training family members to become clinicians or become therapists. This is not a replacement for therapy. We would still very strongly advocate helping the loved one get into a CBT therapy, but recognizing that in many cases that is absolutely impossible in our local area. So seeing this as a way of sort of supporting that. And over the weekend and over the half day, a combination of didactic material, role play, and group discussion. So it was very interactive. In terms of our intervention topics, or our workshop topics, started with an introduction to CBT, ensuring that everybody was on board with what the CBT model was, and then kind of preaching to the choir with the why our families are important, and literally people were like, yeah, we know, that's why we're here, but telling them exactly, this is why we want to put this out there. So those were kind of the two non-intervention topics, if you like. We then moved into the things that would map more typically to CBT. So curious questioning being a phrase that we coined that I actually use quite a lot with clinicians, because I think it sums up very well what we're trying to train them to do when we're doing CBT. It sort of maps onto the Socratic questioning and the guided discovery. Normalizing, this was a huge one for families, particularly thinking through their own loved ones' experiences, their experiences in the context of specific stresses potentially, thinking through their own experiences, their own anomalous experiences, if you like, and where that might lie on a continuum, what was happening in their life during that period. Working as a team would map onto collaboration if we were doing this in a CBT model. So how can the family member work collaboratively as a team member with the loved one? Recognizing and managing stress was very much about the family member recognizing their own stresses, and then importantly, how they coped with those stresses and which of those coping strategies could be considered helpful, and how sometimes maybe they engage in less helpful coping strategies, much in the same way that their family members might do. So they were able to sort of at times recognize, like, you know, my family member has all this going on and then they do that, and when they do that, it's just, I don't know why they do it. But they could see for themselves, gosh, when I get stressed, I always go for that extra glass of wine. Yeah, that's not always my best strategy either. So trying to help people recognize coping strategies and how to choose helpful ones over the long term. Understanding distressing beliefs and voices was really about introducing very, very simple formulation to help the family members begin to understand the link between how a person's thinking about an event, so the event perhaps being a hallucination, how they're interpreting that, how it's impacting their behavior, and how it's impacting their emotions. So very simple formulation. From that, I guess, mapping onto CBT, the intervention would be problem solving and coping strategies. And then we added the talking about medications or wellness planning based on the feedback that we'd had previously, because these were topics that were really huge to family members. So, you know, distilling talking about medications down to how do I get my son or daughter to take medications allowed us to kind of step back from that and think about it from a formulation, how to use curious questioning, normalizing around that. So these were two sort of more specific topics that fitted into the workshop overall. So in terms of results, we saw significant decreases in psychological distress and negative appraisal over the 2 time points from baseline to 1 month follow-up. No significant changes in positive appraisal, emotional over-involvement, or critical comments. And these were all self-report measures, by the way. But looking at the CBT measure that looked at knowledge and confidence, we saw statistically significant changes in both knowledge and confidence over all of the domains, with most change in knowledge and confidence being seen between baseline and the end of the second day of the workshop, which kind of makes sense because this was a time when we were really conveying all of the information. So we would certainly hope to have seen a change in what they knew about CBT during that time. However, 4 domains showed continued significant change between the end of the workshop and the booster session. So normalizing, working as a team, recognizing stress and stress coping skills. And I think my sense is that these were probably the ones that resonated the most and were also the easiest for them to continue to practice during that period. So that's our best guess for why those 4 continue to show improvement. So in terms of conclusions, family members want to learn skills to support their own mental health and their loved ones. I think we saw that in terms of how people really reached out to us, particularly as the deadline for the workshop was coming up, wanting to get in. We ended up with a waiting list because the room wasn't big enough to add more people. We actually had 1 person sneak in, which spoke a lot to how much people wanted to be there. This 2-day workshop in CBT skills plus a half-day booster session resulted in decreased negative appraisal of the loved one and improvements in psychological distress. And family members reported increased knowledge of CBT skills and increased confidence in applying these skills overall. But we have many directions that we really want to go with this. So like I mentioned, we collected that qualitative data as well. Other than a quick read through, we haven't done anything with it yet, so we're going to sit down next and do thematic analysis with the aim of really using that qualitative data to help develop future groups. So very briefly, and what already jumped out and feedback on the day that people were quite vocal about was they wanted a smaller group size. So that group of 46 just felt too large, too overwhelming. Having a 46, it was a big group. Yeah, so it was a big group. So they wanted much smaller group sizes, which makes a lot of sense. And shorter sessions over a longer period. So not having the 2-day necessarily, but 1-hour meetings every week for 4 months, something where they could really form a relationship over that time. Anecdotally, one of the things that was really nice to see in the 2-day workshop was people exchanging telephone numbers, arranging meetups, doing networking. We had a whiteboard for, we wrote up resources and people were sharing resources on there. And I believe out of this has sort of come like a little, that sounds very diminishing, but a kind of a small network meetup group where people have continued to meet from that 2-day workshop, which is really lovely. Made me realize that I should also include a group cohesion measure next time we do this. We want to identify and train a family member to co-facilitate the group the next time we do this. So when we started on the first day, one of the first questions we got was, why are you here teaching us this? And so both myself and my student gave our credentials and our qualifications, but that wasn't actually the question they were asking. They were wanting to know about our personal experience. So we felt comfortable to disclose a little bit of that, but not in any way sort of truly replicating what would happen if we had a family member who'd been through the training, had used these skills themselves, and now was up in front providing that training to family members. So we really want to support that in our next iteration of this. Developing materials that group participants can utilize at home beyond just PowerPoint slides. We want to build on that. And there was a lot of requests and support for more app-based materials and support. That could be a product of us living in the heart of Silicon Valley where everything is online. But essentially this idea that they could have something that they could go to on their phone where they could type in, like, this is happening, and they'd get a little recommendation, like, hey, you could try this, or have you tried curious questioning, or have you tried doing your stress coping skills? So having some more app-based interventions that would support this workshop, I think, would be really helpful. So in terms of acknowledgements, obviously the families who participated in the workshop provided feedback and have continued to provide updates following the workshop as to how they've used things. That was really fun after the first month. People would be emailing, I tried curious questioning last night and it went like this and it was really great. So it's been lovely to get those emails. Liz, my student, who was doing this for her dissertation, and then Nicole Olson, who is one of our group co-facilitators. And I can take questions. I have a minute or two. Thank you. Oh, thank you, Shirley. I was going to say, Shirley's got the microphone. Uh-oh. Where's it going? Is the microphone unmuted? It's getting unmuted. It's all...
Hello?
So yeah, there you go.
Yeah, I saw that
everything.
you noted a decrease in negative appraisals.
Yes.
And I'm wondering if that was, a couple of things, I'm wondering if that was reflected in the EE self-report scale that you had. And related to that, we find ourselves particularly focusing in on the reality of perceived criticism, which is a little different from negative appraisal. It means it involves understanding the hypersensitivity on the part of the patient that might perceive criticism when it may or may not actually be there to an observer. Interested in what you think.
Okay, so in terms of the negative appraisal, that comes out of the family questionnaire, which is a self-report that captures expressed emotion. So certainly we would see that as being reflective of a potential change in expressed emotion. For the perceived criticism, I think that takes us to the point where we really want to capture the data from the consumers as well. So what impact does this training have not only on the family member, but on the loved one? And I think that would be a really good measure for us to be including. So more to do. Luana, just a quick one.
You know me. Hi, wonderful talk, Kate, and really great stuff you guys are doing. Yeah, I wondered, I was going to ask regarding handouts. Did you guys give them any kind, the family members? Okay.
Yeah.
Because that's something that I saw in your future.
Yeah. So we did give them, and I would say it was a mistake, not a mistake to give it them. I think we did it in a non-culturally adapted way. We just gave them slides, like I would if I was training a clinician, which is not particularly meaningful to a clinician a lot of the time, because you're just like, hey, great, my slides, wonderful, thanks. So that's what they had. I think that's something that we could really work to develop, sort of manualized piece, or like I say, I think making it technology-based will be very meaningful to this group. So I think that's something for us to do. But okay, thank you so much. I'm going to switch hats, thank you. And I'm going to introduce Yulia Landa, and I'm going to apologize to Yulia because I don't have my information about where she is right now, but I know she's changed recently, so I'll let her introduce herself. Thank you. Sorry about that.
Hello, everybody. It's a pleasure to be here. Can you hear me well? Wonderful. So I'll introduce myself. My name is Yulia Landa. I come from New York, and the work I will be talking about was conducted at Weill Cornell Medical College, and I currently at Mount Sinai Medical School, and we are continuing this work there. I'm going to continue the topic on teaching family members CBT for psychosis skills. Our CBT for psychosis training for families was developed as a part of group and family-based CBT for use at high risk for psychosis program. And I will talk about this program, rationale for this program, outcomes, and in more detail, I will talk about how we teach family members CBT for psychosis skills. Just an overview, the program consists of CBT group skills for use, and this is 15 lessons they learn over the course of 15 weeks. Youth also engaged in individual sessions that are designed to support group sessions. They are in a group with other adolescents and young adults, and usually it's small groups from 3 to 6 youth in a group. Their family members are in a different group. They learn the same skills that adolescents are learning, and these skills are complemented by a training program where we teach family members how to implement these skills at home and how to interact with adolescents and young adults using these skills. We adapted our training that we have for clinicians, and in this training we use simulated actors that helping us to teach these interventions. We have conducted an open trial, rather small, of these interventions with adolescents ages 16-21, and we are currently finalizing a pilot randomized control trial where we're comparing group family CBTP versus monitoring, and we're also doing a follow-up evaluations in both groups for 2 years, and ages are 12 to 25. We have recently published the results of pilot randomized control open trial, and we are currently conducting a randomized control trial. This intervention is based on the model of what contributes to psychosis risk. We know from different studies that environmental factors could be contributing to developing psychotic episode, as well as cognitive biases, reasoning strategies, lack of insight, and also isolation is a very big factor in predisposition to developing psychosis. We know also from studies that suspiciousness and social withdrawal from friends and family are most noticeable symptoms before person develops first psychotic episode. Therefore, our model was developed to specifically target suspiciousness and isolation. This is our main target. So we use CBT, we teach adolescents and family members how to appraise perceptual disturbances and anomalous experiences, as well as just regular experiences that they might appraise negatively. We teach them about cognitive biases and reasoning strategies that could be potentially contributing into the formation of delusional beliefs. We also target withdrawal and isolation by inviting the adolescents and family members to receive support in a group, and we are hoping to change both family environment and peer environment for adolescents and young adults to reinstall a social feedback system and also social support. Here is our intervention. We have several phases of an intervention. Intervention is 15 sessions. They first learn CBT skills in a group format. They learn about CBT model, ABC of CBT. They learn to identify and correct cognitive biases. They learn about the utility of beliefs. Can we change our beliefs? We put it together, and using examples, they learn how to evaluate and reevaluate beliefs step by step. In a mid-session, all group members collaboratively work together to help each of the group members re-evaluate their suspicious or stressful beliefs. Let me give you an example. So we have a manual, Cognitive Behavioral Therapy Prevention Workbook. The groups are run like in a class format where we have a PowerPoint presentation and each adolescent has a workbook as well as family members has also their workbooks. Let me give you a couple of examples of how it works. Each group starts with warm welcoming. People are continuously doing exercise to get to know each other better. For example, please say your name, share one negative beliefs that you recently changed into a positive one. Both adolescents in their group and family members in their group identify their goals for the group right from the beginning, as well as they identify suspicious or stressful thoughts and beliefs that are interfering with their goals. Let me just give you a couple of examples. Goals, adolescents, to gain techniques that help me ignore the paranoid thoughts, to be able to get through this dark storm that I've been facing for the past year and to get my life back, essentially. And my goal is to be the social butterfly I used to be, just like this character, Usaki, in Sailor Moon, who makes friends so easily, and the friends that she makes, she knows, she can trust them with her life, and I want to find friends like that. So you can see here, the goals are to come back to life, to have friendship, to have relationship, and be happy and function well. Family members, here are some examples of family members' goals. To learn how to keep calm in the face of children's anxiety. I want to develop the skills I need to help my daughter cope with her fear of rejection and the thought that people are saying bad things about her. To learn how to approach difficult subjects, voices, figuring out what is reality and what is imagined. We built our interventions based on CBTP principles and also integrated algorithmization in learning and instruction principle, as well as fuzzy theory by Valerie Reina, which helped us to develop exercises on how to particularly teach new thinking strategies to adolescents. Let me give you a couple of examples. We would first introduce a concept. For example, we are learning now about red flags of paranoid thinking, and one of the cognitive biases, it's about me, personalization bias. We will give a definition of what it is, thinking that most of the things other people do or say somehow relates to you, and give examples. Here is Mary, and a lot of these examples are about Mary. Mary came back home and her Windows was broken. She did take it personally, use personalization bias. What is she thinking? And now she didn't take it personally. What is she thinking? And we have many exercises that would help adolescents develop a skill of how to develop different explanations for various events and situations. Here is another example. Mary saw two women passing by and they were laughing, and Mary immediately thought, they are laughing at me. We teach adolescents how to build ABC model, cognitive model of Mary's experience, and again, identify cognitive biases that Mary has. We teach them about all different cognitive biases that may be contributing into the formation of paranoid beliefs. And we also teach them specific steps, how to reevaluate beliefs steps by steps. Here is an example of some beliefs, stressful interfering beliefs that adolescents identify. It's just the fear of people talking about me and the fear that is going to carry over or whatever into college. And I really don't want that to happen. I want a fresh start and everything. And here is some interfering beliefs identified by family members. The things that happened to my daughter might happen to her again and cause more distress later on. I feel helpless. I won't be able to help my son. I fear that she will think that I don't really believe her, that I don't believe what she's going through. And then family members worked on their beliefs and goals in their group. So how do we teach family members CBT skills? We would first do an assessment via a role play with a simulated patient actor. And then in their group, family members will learn how to apply CBT. We would first explain them specific skills, do video demonstration, and then they will practice CBT skills role-playing with a simulated actor and receiving feedback. And we will do regular assessments via a role-play with a simulated patient actor. Here is an example. Here is a role-play that parents would be presented at the baseline. He would be a parent of a Scott, 20 years old, college student who lives at home with you. And Scott started to withdraw socially and stopped playing games he usually played, and you are concerned about changes in his behavior attitudes. Scott is coming home and want to have a friendly conversation with you. You're concerned about him, so you want to do your best to be helpful to him in any way you can. And parents get a task, engage him in the conversation, show empathy and concern, and be as helpful as possible. Here is an example. Here is now actor and a parent. Give me permission to show it.
Why not? You want to see a doctor? No, I want to see a doctor because I don't want to hang out with my friends right now. But it's supposed to be bothering you. That's let's fix this.
This is very typical.
Okay. There's nothing fixed. I mean,
You want me to call it fun?
why would you call my friends? It's just embarrassing.
Why is it embarrassing?
I'm 20 years old. I need you to call my friends.
Well, then tell them.
There's nothing going on.
But I see you changing. I don't the same things to do. You do it for a guy, hanging out with him, calling on the phone, playing, and all of a sudden, come. That's not normal. Something must be bothering you. Come on, let me up and up. That's what parents for. We'll resolve the problem of the lock, right? You're gonna get a new lock, your combination, after this we go and buy it, problem solved. But the way you behave is not right. Something must be bothering you. I know this is doctor, good.
What kind of doctor do you think I need?
So.
Okay, I'm gonna stop here. So this is a very typical pattern. This is a baseline role play. We develop a scale, CBT skills for family scale. So we will rate the performance of these parents, and we will also identify his strengths. For example, he exhibited genuine concern for the son, offered possible solutions, tried to encourage son to open up, but he can benefit from a lot of skills, such as summarizing and reflecting back, learn how to normalize experience instead of saying this is not normal, guided discovery, how to help child resolve ambivalence, and also to praise his efforts. To teach parents this, we developed cognitive behavioral therapy skills for families workbook, and we have 16 skills that we are teaching them. Those are based on exactly the skills that we are teaching to clinicians who learn CBTP. Here are some of the skills, and here is examples. So we show parents examples how to do it and how not to do it. Let me just show you a few. Too fast. And we also demonstrate the skills in videos. So we developed different videos with, here is just a quick example.
I guess they knew me or me.
You are popular. There's so many people. But that's just kind of your life when you're young, you know all these people, you go out to all the bars and the clubs. That's a really fun. What did I do that was helpful for you? And what did I do that kind of pushed you away and made you kind of close up?
You kept changing topics, even though it was clear that I was very upset about something. That wasn't very helpful. Mom, the people were laughing at me on the train.
What? Oh, stop it.
Well, you think I'm crazy? You think I'm making it up? And you were dismissive of what I had said.
So if anybody interested in our videos, you're welcome to go to our website, icanfeelbetter.org. And yeah, I'm just a little bit worried about the time. Yes. But I'm happy to talk after. So we teach the skills with an actor in a room, and they would bring their own scenarios, situations they face at home, and we also provide them with scenarios that are very typical and practice the skills. Let me just quickly show you some results because we just have a couple of minutes left. These are results of a pilot open trial. We assessed different domains. We looked at psychopathology symptoms, psychosocial functioning, information processing style, therapeutic alliance. We had good results. We have all our adolescents basically recovered from attenuated risk status, They had big improvements in functioning and decrease in both attenuated psychotic symptoms, anxiety, depression, cognitive biases, improvement in functioning. Interestingly, increase in family members' empathy as perceived by adolescents. Parents also improved in their CBT skills assessed by our scale. And these are specific skills that we found significant difference in the open trial. And we just analyzed first 6 family members from our pilot randomized control trial. And overall, we see improvements, specific skills that are improving, interestingly, summarizing and reflecting back, normalizing experiences, collecting evidence for beliefs, offering an alternative explanation, and just one example.
Program where the parent and the child learn the same information. So what Benjamin learned, I learned, and so I was able to, I am able to help him redirect his thoughts, if they should go towards paranoia again or anything like that. When you had these paranoid thoughts, there are these people on your cell phone, they're on the bus and they're trying to talk to me. I didn't know what to say to him. I was just adventurous. That's not real. That's not real. But what I've learned here in CBT is, to identify what it is, identify the event, and then try to find evidence to support what he's saying, to help him. Okay, well, they're trying to reach you on your cell phone, on their cell phone, on the bus. Let's look at different options. Why would they be doing that? Can they do that? Do they know your number? How can they reach you? That sort of thing. And I don't think about that.
And just in case if video wouldn't work, I had it written up. So in summary, as the treatment was well received, we have decrease in symptoms. Adolescents seem to be recovering from a high-risk mental state. We continue our pilot randomized control trial, and of course the limitation is a very, very small sample. So we currently planning a larger study. It's very hard to recruit patients at risk, even in New York. So if anyone is interested to collaborating on this project, we would be delighted to work together. And it seems that family members are able to learn and to implement CBT-P skills at home. Just want to acknowledge my mentors and consultants, as well as my lab of wonderful students and volunteers who help with this project.
And with that, thank you so much. Thank you for everyone for being here. Thank you to the presenters. I appreciate it. And we'll move into the next symposium. Thank you, everybody.